So our panel today, we have Dr. Jane Williams, who's just spoke to us, Mr. Ian Kamali, who spoke to us earlier, Dr. Helen Lyang, Dr. Timothy Ritzman, who is our neuro-oncologist here in Nottingham Children's Hospital, Dr. Helen Spoetis, and Louise Robinson, who is our neuro-oncology specialist outreach nurse in Nottingham and an absolute vital member of our team. So really what we'll do first is just open up the floor to questions for any of the members of the team. If I can just ask any questions, if you can raise your hand, and then we can get you the microphone. And then once you start speaking, and remind my speakers, please, to remember to speak into the microphone as well, please. So anybody, any questions for the panel? We have stunned silence.
What's been the best bit? What do you think has helped the most?
Maybe I can start with a question. What do you think is the biggest challenge to achieving what we have all been talking about and longing for today?
Microphone, please.
So I think part of it is money. I said yesterday it's individuals. So if there are individual champions, the song, you might have a very good song, but it doesn't hear very well if you haven't got a very good singer. So individual champions, and we've had examples of good practice here in Nottingham, which is an exemplar. But I also think when people are very, very busy and feel overwhelmed, and where you're in situations of very high density, maybe there are language barriers, it's very much harder to deliver for your patients, however much hard you try. And I also think that collaborative networking, which is very clear here today, and having support from your colleagues rather than being seen as an outsider who might be critical when you're actually trying to advocate for change, would be helpful. But I think money would help because a lot of people will say, that's not my job, I haven't got time. When you're coming up against that all the time, it's not helpful. And however much we run our HPAT forum, we very rarely have surgeons there because they're just too busy and they've got an operating list somewhere, and yet we need them desperately. And the oncologists are also too busy because they've got MDTs elsewhere, so they don't prioritize this because rare conditions are rare. So I do think that we have to think about how we organize services to get the rare conditions in one place, and how we raise awareness of the fact that that a brain tumor does cause a brain injury.
Can I just add some things? I think we've seen today that communication and education is absolutely vital in this area. That, for years and years, every child pitching up with a new brain tumor, we get the same story. They've been back and forwards to various health professionals. David Walker, instrumental in trying to change things, and how much that's helped is still, it's happening. Every child that pitches up, they've been backwards and forwards, and looking after young people for years. I've absolutely seen that in the clinic. They have neurodiversity, they have mental health issues. That's great that that's being recognised more. It shouldn't just be recognised. People should be educated, the healthcare professionals looking after all these young people, that this is something that is key and essential, and every young person should get the services that they need when they need them. The national advisor groups that we were talking about, these are such rare things that to have expertise nationally is such an important thing. But as Helen says, it's an expensive thing. There's a group that is run from Richard Grundy from Nottingham, looking after ependymomas, another specific tumour type in young people that's had a national group. That has only been funded because there was a trial that funded it. Before it started in the early teens, about just low 40% of patients had a complete removal of their ependymoma. Last year, our national audit showed that figure was 89%. And that's since that group came in. And having a complete resection for ependymoma is a massive advantage in terms of survival. So it's getting information like that that's vital, that you can go back to commissioners and say, yes, this is expensive, but it's actually worth it. And what price do you put on a child's health, life, and quality of life?
I'd like to make a brief observation, and then, can you hear me okay? And then ask a question. So I am a trustee of Success Charity, and I'm looking at what's written on the board behind you, convincing authorities to change. So two things have struck me today. When we learn about the Nottingham story and how they started, it was through a cost benefit. It was making the case not just emotionally or generically, but talking in numbers and terms. And I think that's something that we will all have to do. We'll have to make that case in tangible ways. Everybody would probably agree in here there's unmet needs, but making the case of... And the other thing that struck me today was somebody mentioned Italy, where you're 10 times more likely to get in terms of quality and provision of rehabilitative support. So they must have had cases. There will be we've got evidence from Nottingham, but maybe we should seek evidence from some of the countries around us, including Germany, because they would have made calculations that showed that investment here was worthwhile. Do the board have any comments on that, on how we can shape this collectively so that the case that's made is a winning case?
Thank you for the question. I just wanted to point out that sometimes it's not necessarily that they have better evidence in other countries. They just value different things more. So I didn't have the data, but I was interested when the data was shown about rehabilitation. I can give you the data on child and adolescent psychiatry. In France, Germany, and other places, the number of child psychiatrists per 100,000 is 12 plus. I think Switzerland or something has 21 child psychiatrists per 100,000. The UK was down at 6 child psychiatrists per 100,000, which was equivalent to pre-war Ukraine. So that's where we are in terms of funding for mental health in children in this country, not because of any difference in evidence, just this is how we value it. Coming back to the earlier question and a little bit answering your question, I think how we convince the authorities is, and even as you mentioned with the NICE guidelines, is research, because people will not change what they're doing unless there's evidence to suggest that they should be doing something different. Research takes money, but research can also begin on the ground with yourselves being happy to participate in research. As a researcher, even just talking to you guys today, I've already thought, maybe there is something that I can do, with my own research funding. If I had research participants, as I mentioned earlier, a lot of you took part in a questionnaire, so now I have initial data. Maybe then I can think of some other research that could be done pretty cheaply to start building some form of evidence base to apply for research funding, to then start building the literature base to be able to change the debate.
I think your point about what we value is really key. I think we need to change what we value as a society. I think money is important, but I don't think right now it's maybe the key thing. I think in my professional experience, the key thing is recognition of this concept that this is an acquired brain injury. Denise will know my bugbear of referring, just a story of referring one of my patients to a community paediatric service. I had to write a letter, and I felt like I was trying to be very persuasive, and actually that I shouldn't need to be persuasive. That should be accepted widely across all services, that this is needed and this is required. And then I had to fill out a form, again, had to be very persuasive. And then the referral was rejected. And if we're doing that at the level of our community paediatric services, and it's not every service within our region, it's some, then what hope do we have? We need to get that recognition, because even if we had all the money in the world, if we haven't got the recognition, it's not going to get spent in the right way.
Thank you. 2 points. What Tim has just said about him having to make the case that this child who's had a brain tumour needed to have long-term follow-up in the community, and it being rejected, is very disappointing. If he'd written a letter saying I think this child's autistic and needs an autistic assessment, it may then have been put on a waiting list. And it goes back to what Matt was saying and you were saying, it's that splitting the hairs that many of our professional teams are saying, it's not my bag because it's not being cloaked in the right terms, is very annoying. And we do need to communicate that, improve the knowledge base, that is very much the job, and you are making the correct referral. And I wouldn't have rejected that had I read that, as you can all tell. And just going Phil's point, how do we made a cost-benefit analysis. That's how we established the case of need for the early paediatric neurorehabilitation team by said if you put a rehab team in, children get out of hospital happier, fitter and earlier. And we proved that was the case. So wow, everybody pleased, because beds cost a lot of money on bed stays. If you can then prove that child's life outcomes, and so what's happened in NHS England, when we use the terms life course. So if children, if you allow me to say Ellie, like Ellie and Star, who are doing so well and they attending school now, Ellie was 60-odd%, now he's gone up to, because of the intervention, and Star's in employment. If we can then translate that then the whole investment, because can you imagine a government or a healthcare system who invests all that money in the treatment of a brain tumour, the Ian Kamali's, the Donald MacArthur's, the Tim Richmond, Louise, the whole team, the drugs, the chemotherapy, the radiotherapy, and then the parent is weeping for a physiotherapist 5 years later, or a specialist teacher. I mean, it is ludicrous, totally ludicrous. And so putting it in lifetime course, if you could invest this money here, and you then will get an individual who's attending school, will achieve their best selves, and then they'll get into employment, pay some tax, and then you will get the message across. But that takes time to collect that data. So we have to do it in smart ways, and the smart ways are school attendance, that's quicker, and happier, emotionally healthy people. And if you can get the longer story, that's the best. That's even better still.
Could I very quickly add an answer to that question of how you convince the authorities? So I've been on the National Clinical Reference Group. It's the advisory group for the National Commissioners for many years with Jane. I think it's 12, 13, 14 years I've been on that. The very first meeting was talking about paediatric rehabilitation and the service specification, and it's still not been finalised yet. However, there was a bit of work. The only thing that immediately got sorted out was a response to the Cumberledge report of fetal teratogens, and immediately a service was set up and funded to respond to that. So it is unfortunately politically motivated. As Helen has shown you, she went to a Lord and got in where she needed to speak to. And that's the reality of it. It clearly should not be the way, but unfortunately it is.
Can I make one more point as well? David Walker would say this, so he's gone, so I'm going to say it on his behalf. But it's also how we do research. So currently, clinical trials, we build research to look at survival, which is clearly very important, but we also need to look at outcomes other than survival, so quality of survival. And there are some clinical trials starting to do that, but it needs to be embedded and it needs to be part of the discussion when we're setting up a clinical trial and involving patients and families and survivors in designing those trials, so we can ask the right questions in the future.
And I think it's also involving the right professionals. So I don't know how many years I was a member of the Children's Cancer and Leukemia Group, and I was a founding member of the Quality of Survival Group at the International CEOP. And there was a neurologist. I think that the neuropsychology element has been well represented, but neurorehabilitation is not. And I was the only endocrinologist for 20 years. And I think that one of the things we're trying to do here is to make sure, so one of the reasons why there's no awareness and why you're getting these rejections, it's not something that Jane and I would recognise from our experience of 45 years in the NHS. It's changed a lot because there is such a huge demand, and it's a way of rationing services. It's also a way of delegating down to less costly services. So they hive things off to different professionals. And I think that the neurorehabilitation, or what we've been calling late effects, I think I'm hearing from the nurses in late effects services that children with brain tumours are different from other cancer survivors. They deserve a pathway of their own. And I think they do need new specialists who have a holistic background. And I think that's another area of education that I would like to see success building. And with respect to the research, we are thinking, I would love to collaborate with more. We've got Success Connect, which is professionals interested in survivorship, to try and decide how we measure these outcomes, provide the data registries that are needed, and also undertake the health economics to show that. And you're the experts in research, but this is health service interventions, and it's a different type of research. But we would be interested in trying to understand that better and in collaborating with centres.
Thanks, Helen. Donald, I think you have a question.
Yeah, a comment more. Phil's asking the professionals on stage how they would convince the authorities to change. In my experience, often it's the patient and the parent and the public voice that is more persuasive. You know, when I've been up against decision makers and managers and so on, often it's the patient's voice and the public voice. And I think what Success can do well is empower people to speak together. And I think there's different sorts of research. You can get quantitative research where you spend a long time looking at costs and details and times of very granular data, or you can get qualitative research where you see the same recurring themes come through about people feeling unsupported or being diagnosed late or not being supported as they go back into education. And I think a relatively limited body of qualitative research showing these same themes that's then pushed again and again at the authorities is probably the most efficient way to make a difference in this kind of field.
I would echo that, and I would say I didn't plan to set up a charity. And I've taken lots of knocks on my shoulders from my colleagues about, what the hell are you talking about? You're mad. And I feel that the fact that patients are coming to the charity and that they are speaking out is what's given me the mandate. And I've gone to Parliament with that mandate, and that they've convinced that's given what's convinced the door of NHS England.
Thanks, Helen.
The press next.
So I think what might be helpful for a couple of minutes is to have a think, and really we want you to be part of this debate now. So just having a think of, if you were to help with, see if I can get the slide to change. Oh, let's see if you can help. So if you were in power and you were able to help us decide what professionals you think and what teams would be involved in the recovery MDT, can you help us to actually prioritise, with this list as an example, really, of who you think needs to be there? So top three.
think for me, fertility's always been in the back of my mind, but something I've never dared to ask because of being so young. I think it's a prioritised thing that should be mentioned early on, so you didn't know what to expect and what could be the possibilities really. So I think that's quite important.
Thank you, Sheehan.
I haven't got three, but education and learning is so important for me. I haven't really got that far down the list yet, but I do think education and learning needs to be right at the top of the list. Somebody was saying earlier on, education is part of rehab, and it really is. It's a really important part of rehab. So I think the work that we do with schools and helping schools to understand brain injury is really vital.
What about vocational assessments on what is the right work and access to work? And do you know about schemes?
Helen, sorry, microphone.
So I think there are probably different teams at different times. And at the moment, the services, and this is no disrespect to anyone, but at the moment, the services are aligned to oncology all the way through. And the focus is on the tumour, and naturally, because that's what nearly killed you. But actually, I think for the longer term, it would be helpful if some of the other services were gradually taking over. And in adult life, a lot of adult endocrinologists end up because they're physicians. But I think more neurodisability services need to be there. And I think young people need to be helped to understand how they access work, that they have assessments of their work strengths. We all have strengths and weaknesses, and it's helpful to undergo assessments at that stage to tell you what you're good at and what you might be able to do. And I don't think we do that very well, and I don't think we know what support exists, like support carers or support, how you can actually have a PA. And I think of that as a secretary, but you can have a personal assistant who helps you go to work and helps you become independent. And how you become independent, I think, is very important. And I don't think those of us in the paediatric world know that, and there is a lot to do with the adult transition in that.
I think we're all going to start saying that our own area of interest is the most important. So I am going to have a shout out for psychiatry. And the reason that I'm saying that is because I think mental health, because I think the things that you mentioned as being really important in terms of access to learning and education and the vocational and access to work is undercut by having good mental health. Because I feel that your limitation of your potential is mainly down to mental health rather than ability. You can have people with amazing abilities, but actually don't fulfill that because of poor mental health. So I think mental health undercuts learning and the vocational.
I think it's really hard to prioritise out of that list. I think it's really difficult to prioritise out of that list because they are all important and they all can appeal to you at whatever part of the journey you're on. If we'd have came here last your roadshow and had that last year, I would have said, oh, what do you think, Star? And it would have probably been the vocational assessment and accessing to work, But this year, it's more fertility and it's whatever part of life you're on, I think. So it's really hard out of all of them to say, oh, well, you need to maximise the top three because it just depends where you are in your journey.
Have you been able to access them all?
No.
That's my point.
Yeah, it's hard. It is hard.
Would it be helpful? So we're making a booklet, we're adding neurorehabilitation to it at present, but we've got a life after cure booklet at the back, which we are. We've got a life after cure, surviving a childhood brain tumour booklet at the back, which we did about 3 or 4 years ago, and which we have got some help from a drug company to update. And it included the diagrams of the brain and some neuropsychology assessments and how you might need to face educational challenges and where to go for help. And we're updating them now with a neurorehabilitation section. But we felt it was important that families knew what the best standards were and how to do that. And so we're looking for updates, but please have a look at the last book. Yeah. And I think we're running out of time.
That's what I was going to say. I think we'll leave it there. But can I just thank everybody for your participation, for your interaction. It's made the day so much easier having more interaction, talking backwards and forwards, and also to our fantastic panel as well. Can I give a big round of applause and thanks to everyone.